So, Dr. Klauer, the first question is, what do you suggest for apneic patient who suffers from congestion due to allergies?
So, part of our evaluation, we're looking at the nasal passages and we're also observing them breathing in the office. And so a lot of times I I find patients who are, I hate to say misdiagnosed with allergies, but they're diagnosed as allergies, but they have a massive bone spur or a nasal valve collapse. And we'll recommend they get in front of an ENT to determine if fixing that nasal obstruction uh, will help improve their ability to deal with and manage their allergies. So the reality is you want passive, normal nasal breathing, not hyperventilation, and you want that nose as clear as possible. And just so many of our patients are walking around with congestion. So our ENTs, what they want us to do is put a patient on Flonase Sensimist, clear nasal spray, nasal mutes, or breathe right strips for 3 to 4 weeks. And then if symptoms still persist, get them over to them. So oftentimes that's kind of the protocol that we'll follow based on the recommendations of the ENTs that we work with.
Okay, thank you. Next question, is there a way to measure airflow and air volume? And how important is this to CPAP or dental appliance therapy?
Yeah, so you can measure air volume with a rhinometer. You can measure airflow with a rhinomanometer, which can be applied into the nose. And those are both valuable tools to quantify what's happening and what you're doing and what norms are. Sadly, they're not utilized by any ear, nose, and throat doctors. And they're not reimbursed by insurance. And so the biggest aha I had with the ear, nose, and throat doctor was I'll show you a picture of her just to give you perspective. We had where is it? Here it is. Dr. Kevin right here. So I was having dinner with her and her partner, and she said, you sent me this woman, and you said you thought her nose needed fixed, and I didn't think the bone spur was that big, so I didn't do it. She came back 3 times, and she said you were insistent on fixing it. So I took her to the OR just because you wouldn't stop, you wouldn't drop it. And to this day, that is the most profound improvement I've gotten, and the most thanks I've gotten, and the best feedback I've gotten from any septoplasty I've ever done. And it did not seem like that big of a spur to me, but I operated because she was insistent and you were, and she, to this day, the biggest thank you I've ever gotten. She goes, how did you know it would be that insignificant? I said, because she had a lot of symptoms of nasal congestion, her dental arch was super narrow, all of these craniofacial symptoms that told me that her nasal airflow was affected. So now my ENTs, they look at my workup as added symptomology that might push them over the edge, if you will, to operate on a patient, aside from how many colds do you get, how many sinus infections do you get, what's your perception of your nasal blockage. But if they see these craniofacial distortions that we can likely attribute to the nasal dysfunction, then they're more inclined to operate. So I found speaking to the symptomatology and the symptoms is going to be far more effective than showing an ear, nose, and throat doctor, hey, look at this nasal airflow rate. It's not good, because they don't use that equipment, and they're not familiar with it, and it really won't. It's great if we're doing research. It's great to quantify the changes we make. So I'm a big proponent of that technology, but it's not going to really get a physician to do anything different, in my experience or opinion.
Okay, thank you. A question about SPG. It looks like a 2-part one. Is it only diagnostic or therapeutic? And how might it be involved in PTSD?
So it's both. It can be both diagnostic and therapeutic, and it is supported to help with PTSD. So if I'm doing off-label uses of it, concussion, things like that, I usually consult with the physician or the neurologist. and say, hey, what do you think about doing such and such? And they'll say, yeah. And so I said, oh, after discussion with Dr. Ross, a neurologist, he recommended, SPG block could be effective. And what's nice is it's 2% lidocaine, viscous lidocaine, very, very low risk, very, very minimal side effects, very, very easy to do. And it's pretty cost effective as well.
Okay, next question. Is there a difference between decreased delta sleep versus REM sleep?
Yeah, there's a difference between your different stages of sleep and what that means. I often tell patients that um, stage 3 sleep, it decreases as we get older. That's our physical restorative type sleep. REM sleep is our cognitive type sleep. So especially in growing kids, you want to make sure that they're getting the growth and development aspect of sleep. That's when our bones actually lengthen. That's why growing pains happen at night. And so that's what's great about in-lab tests. It gives you the sleep staging. Some home tests can do it. They do it based off algorithms. And some sleep physicians hang their hat on the sleep staging and home sleep tests, and other sleep physicians I work with say it's not good, it's not useful, it's not accurate. So I think the most important thing is us being dentists is to get as calibrated as we can with our sleep physicians and communicate with them effectively, and don't overstep our role that we have in the sleep disorders world, and really communicate well effectively with our sleep physicians and have a good rapport and relationship with them, because we can't do it without them, and we don't want to overstep or practice outside of our scope.
Okay, finally, we have a comment from a member who says, I have Ehlers-Danlos, mast cell activation is my problem, not allergies. Screen for it. Do you have a comment?
Yeah, we see a lot of Ehlers-Danlos patients. One of the world experts of Ehlers-Danlos is right in our community, Dr. Heidi Collins. And so I probably make a referral to her, I don't know, 5-10 times a month when we suspect mast cell activation disorder or Ehlers-Danlos. What's really easy to do is a Baton score that can help you screen patients for Ehlers-Danlos or hypermobility. We as dentists can't diagnose it, but we can suspect or make a referral appropriately for it. But yeah, patients with mast cell, Ehlers-Danlos, other things can certainly have increased nasal congestion, allergy-like symptoms that may not respond to traditional allergy treatment. And I feel for those patients, because usually they've been to so many providers, so many people, and they find out 7 to 10 years later, and it's a management type disease. So you just have to learn how to deal with it and how to cope with it, and how to symptomatically treat yourself and broaden your adaptive range, because there's not a cure for it. But it certainly is a big part. And I think that it's really, really important that we have that on our radar, just like we do other stuff. I mean, we have so many things that we have to try to, I'm going to just pull this up. We have to do our best to figure out what's wrong. But a Baton score is an easy hypermobility test. And this is what the physician told me to do. Basically, it's a out of 8. And where's the picture? Oh, it's out of 9. So here's the picture right here. Bend the pinky back on each. If it goes past 90 degrees, that's 1. Bending the thumb back, hyperextension of the elbows, ankles, touching palms to the ground. So you can do these maneuvers on the patient really quickly, and you can say, oh, the Baton score is greater than 4. It's indicative of hypermobility. We recommend they follow up with, said person to look into that more.
Okay, you said something really correct or heartwarming, because our member writes back, so happy to hear you say that. I was only diagnosed at age 54. Thank you so much. So that's good to hear. We actually have a link to everyone from Sharif regarding Ehlers-Danlos. We'll leave that up for, oh, and I lost.
Yeah, so here's here's Dr. Collins that I work with. And so if I suspect it with a patient, I'll kind of go into patient mode. I say, now I suspect you have symptoms of this syndrome, and I can't diagnose it, but a good friend of mine, a physician, she said, tell patients to live on this website and educate themselves just on this website to start. Don't go on other websites, don't go on other chat groups and drive yourself crazy, but read this website. And if it rings true to you, then it's probably worth looking into. And I just pull up this part and I just say, read this, I print it out, take it home. And if you have a lot of signs and symptoms of this, then it's worth, it's worth looking into. And that way this is a medically based site, good information, good resources, and they don't go on kind of a wild goose chase trying to treat themselves. So that's an easy, good website. So thanks to me for sharing that. And that's what we use every day in our office. That's cool.
Okay, another question. Do you have any experience with a patient that changed from a chronic mouth breather to a nasal breather at night during sleep? Started to complain about generalized jaw pain. That's a long one. Do you want me to reread it?
No, I got it here. So yeah, I mean, we have to appreciate habituation. And, we see this sometimes if we do a tongue tie release or we're doing myofunctional therapy, a patient complains of pain because we're actually getting muscles to work how they're supposed to in a fashion they haven't worked before. And it's like rehab. You gotta relearn how those muscles are working, and they might be underdeveloped. And so sometimes we have to hit the brakes on our myofunctional therapy because we create muscular pain. Especially sometimes right after we do a tongue tie release, patients have new pain in the neck because the muscles of mastication and tongue and breathing are just functioning in a completely different fashion. So, that's why good documentation on the front end and good follow-up and, adjunctive care like laser therapy, mouth muscle release exercises, topical pain creams, all of that stuff can be super helpful in some of these patients.
Thank you. I'm wondering if you use wearables in your practice, and if you do so, what do you recommend?
What do you mean by wearables?
Rings that will give you some sense of
Yeah.
oxygen depreciation at night, that kind of stuff.
Yeah, so the sleep, I'll take that in two parts. So the sleep tests that we use are Metabite and WatchPat 1. Those are the ones that the physicians we work with, prefer and have recommended. And as terms of wearables, me personally, I don't wear them. I don't want to sleep with batteries and electrical activity on me. I think it can be potentially disruptive. I don't have any, data to support that, but as you all know, we have electrical current and activity going throughout our body, and I personally don't want to disrupt that. I tell patients, if you're wearing a ring, a Fitbit, an Apple Watch, it's good data to compare to itself, right? Like apples to apples. But almost everybody I know with a wearable will give me an instance of, oh my God, I was up all night and it said I slept great. Or I didn't even sleep last night and it said I slept great. Or I slept great last night and it said I was moving around, but my covers weren't moved around at all. So I would have to dive into that more and research it more. But I find that the three questions I ask patients are, can you get to sleep? Do you stay asleep? And do you wake rested? And if I want data, good data that I can treat off of, sleep studies best, but we'll do the Snore Lab app. And, I'll look at that data when patients have it just to draw some correlations. But I certainly think it's useful and it's helpful, but I don't know that I would hang a diagnostic decision solely based on that, but I think it's useful data.
Daniel, I just want to thank you so much. You clearly have lots of information, and I was tempted to ask you to do a few more cases, but I know that would go on for a while. And so thank you so much for coming.
My pleasure. Thanks for having me.
And have a safe winter and we'll see you all in a couple weeks. Thanks, folks.